Hello, everyone, and welcome to this episode of Medtech POV, the podcast brought to you by AdvaMed, the world's largest trade association for medical technology companies. I'm your host, Scott Whitaker, President and CEO of AdvaMed. And today we're pleased to have not one, but two guests to talk about a New York Times story and what it got right and what it got wrong, what the potential consequences of this could be for patients. Our first guest, Dr. Peter Schneider, is a professor of surgery at UC San Francisco. He was the founding member and chief of the Division of Vascular Surgery at Kaiser Permanente in Hawaii, where he helped to develop a diabetic limb treatment program, among other critical programs for patients, and also oversaw the development of the first endovascular operating room in the Kaiser system. He is a past president of the Western Vascular Society and has authored several books on various aspects of vascular surgery. Dr. Schneider founded two medical device companies and has also been awarded numerous patents. Our second guest, Justin Klein, is a familiar name to Medtech POV listeners. He was one of our first guests on the show. Justin is a co-founder and managing partner of Vensana Capital, a leading venture capital and growth equity firm dedicated to medtech innovation. Justin serves on numerous boards in the healthcare space, including here at AdvaMed. Justin has an MD from Duke and a JD from Harvard. Gentlemen, thanks for joining the Medtech POV podcast. It's great to speak with both of you about such an important issue.
Our pleasure to be here.
Thanks, Scott. Great to join you.
We're here today to talk about a story that ran in the New York Times back in July. It's titled, "They Lost Their Legs. Doctors and Healthcare Giants Profited." The story highlighted a very difficult case, a very sad case too, I would say, and patients who are in the story certainly deserve our sympathy. I look forward to sort of getting a better understanding and clarifying some of the perspectives in the story to get a sense of what they got right and maybe some of the things that they left out of the story that could have brought it to better context as well. So the story itself seemed to paint an entire class of doctors or practitioners with a very broad brush. And if there's one big concern about the story itself, it's the lack of, at least in my opinion, the full context or the bigger picture. There may not be any factual inaccuracies per se, but as is so often the case with media stories, what's left out oftentimes is more important than what actually makes it into the story. And so I think in that context, it would be really helpful to get your sense of the story as well, and maybe the issue more broadly. The story tackled a very narrow health issue, and Dr. Schneider, something you've dealt with in your professional career as well, peripheral artery disease, or PAD. And within that disease state, a particular procedure that is oftentimes used to address the underlying health issues that some of these patients have. So, Dr. Schneider, let's start with you. Talk about PAD and give us a better context of that disease itself and the challenges it poses for patients.
This, I think, is really important, and it's probably too big a subject to cover in a single article in the New York Times or really anywhere else. And so just to be fair, I think the fact that we only really learned part of the story is not too surprising. But PAD, it's really a major problem in the following way, that there are millions of people worldwide, including a couple million people in the United States that have peripheral arterial disease. And another way to think of it is people call it hardening of the arteries, if you've ever heard that term. And basically what that is atherosclerosis. And atherosclerosis is a complex process, but the arteries literally do become hardened with calcium, with calcification. That's important because part of this story is about atherectomy, and atherectomy is specifically designed to manage or to drill through or to debulk, if you will, calcification. So I'm sure we'll come back to that, but PAD anyway is ubiquitous. It's becoming more and more prevalent for the following reasons. The demographics that we know so well of many people aging up to the 65 and over age group. But there are also other features at play. One is that we've become very successful, prior to COVID. If you looked at mortality rates, they were dropping in every state in the United States. And those mortality rates were dropping mainly because of better cancer treatments and better heart treatments. So if somebody has a heart attack, they go into the hospital, they're being measured on how quickly they can get that patient in for a coronary, for a heart stent, to keep the artery open, keep the patient alive, keep the patient's heart muscle alive. Well, all of these things have had an impact. It's what we've hoped for and wished for. But at the same time, some of these more chronic type situations like PAD, which takes decades to develop, is now being manifested in patients. In a previous generation, those people wouldn't have lived, but now they're living decades longer. And I would be remiss if I didn't mention the also rising prevalence of diabetes. And diabetes in particular is an accelerant for PAD, and not just average everyday PAD, but highly calcified PAD. So the amount of calcification we're seeing, the amount of, and when we say PAD, it sounds so benign, but basically what this is the arteries that feed different parts of the body are literally being choked off with an accumulation of debris. If you've ever lived in a house that needed pipes replaced and you dug up some old galvanized pipe and you look down the barrel of one of those and you can't believe that water was getting through, well, that's how people's blood is flowing to their kidneys, to their brain, to their lower extremities, and sometimes to the heart. And that's, what I spend my day dealing with. Let me add one more thing before I pause, and this is super important because it goes back to the article. PAD has many manifestations. The mildest form of PAD may be that the person may have blockages. They don't even know it yet because they haven't had any symptoms or manifestations. A slightly more severe stage would be if there were blockages in the legs, for example, and the person couldn't walk far enough, because when they do, the amount of blood they need going to the muscle increases dramatically. And if you have a fixed narrowing there or a blockage that's not allowing the blood to get through, then that leg hurts, the person has to stop. This is a big deal in people's lifestyle, but this is not something that necessarily commonly would lead to limb loss. It's only a minority of patients. But there's one more manifestation that's more severe. We call it CLTI, or chronic limb-threatening ischemia, which is almost like modern-day leprosy. This is a situation where the leg is so devoid of blood supply that it's literally dying on the vine. Right. They've got an open sore. They've got a stubbed toe. They've got a blister on the foot that then turns into gangrene. I mean, gangrene is something you would think about from a Civil War movie, not from 2023 modern everyday healthcare. And yet that's what it is. And when a patient has gangrene, they need urgent care. They typically do need a bypass surgery or an intervention, and they need it not just urgently. Even when done urgently, not everybody is going to keep their leg once they've deteriorated to that condition. And if you look at CLTI, or chronic limb-threatening ischemia, and you look at the mortality rates for CLTI are higher than they are for breast cancer. There are only two kinds of cancer that are worse than CLTI. One is pancreatic cancer. We probably all know somebody or have heard of somebody who died of pancreatic cancer, Steve Jobs, for example, and there are many other examples of famous people, because it progresses to the point where it's untreatable by the time it's discovered. And this is it's not quite like that, but it's close. Right. In terms of mortality. Anyways, I'll stop there because I know you have a lot of questions, but this broad spectrum of PAD and the fact that the worst PAD is like a cancer is something that was not really brought out in the article. Yeah. Even well-treated patients who present with CLTI, some percentage, 10%, 20%, 30%, will lose the leg, depending on how severe the infection and the gangrene was when they presented.
That is really helpful context. I appreciate you sharing all of that. Let me back up just a little bit to how is it primarily diagnosed, and then what are the different treatment options when it is diagnosed? I assume to some degree it depends on the stage at which it's diagnosed, but can you talk about that in a little more detail?
Again, typically patients usually have a reason to show up to the office. So in that CLTI form that I mentioned, somebody may have a wound that in their earlier days would have healed rapidly within a few days. Now it's been festering for some days, weeks, even months. They could have a piece, an open sore, or even a toe that has gone black, or a wound on the foot that is growing instead of receding. That's how CLTI very often presents. Sometimes it presents because the patient is terribly infected and they've got bacteria circulating in their whole system because this wound has allowed a portal for bacteria to get into the body. With PAD that has not deteriorated to that case, to that situation of CLTI, very often people have what we call claudication. Claudication comes from the Latin claudicare, which is, apparently the Emperor Claudius had a pretty severe limp. And the word for claudication, to limp, is something that we use today as a medical term. And I've had somebody in my family that had claudication. And honestly, if you can only walk 30 feet at a time, this really makes an impact on your life, on your cardiovascular health, on your ability to complete the activities of daily living, this kind of thing. And so typically when somebody does present with claudication, initially, the initial treatment, almost regardless of the severity of the presentation, we treat it medically initially, because very often things like stopping smoking, careful control, better control of diabetes, better compliance with medications like blood pressure medications and cholesterol lowering medications, all those things will help. And very often if a person does those things and really pushes themselves to walk, almost like they're really truly exercising to the point of discomfort, very often those people will have improvements which will allow them to avoid a procedure or avoid an intervention to try to reopen blockages.
Okay.
And that's typically how that presents. So again, it's a range. It's sort of like if somebody says, hey, I just found out I have cancer, they need to fill in the blanks. Like, is this a little skin cancer on the back of the forearm, or is this stage 4 lung cancer? So you have that wide variety of potential, and you have to respond. Our system, our doctors, our practitioners, you may not be telling your symptoms to a specialist. So very often you start out with your main medical, your primary doctor, or somebody like that who hopefully will recognize what's going on and get you to the right place.
The story also talks a lot about the surgical treatment, the atherectomy, right? And you mentioned there's some things you can do medically before you get to surgery. If you can reflect on that a little bit, what did the story get right and what did it not get right about the surgical versus non-surgical manner to treat this disease?
This is an important question. Again, you can tell by the way I'm describing it, it's a multi-layered, highly nuanced situation, but I'll just say that patients with no symptoms can still have a problem, because you can have, especially if you're diabetic, and let me just give me 1 second to explain. A diabetic patient very often loses some sensation in the feet. So a diabetic patient can have what we call neuropathy or nerve damage from the diabetes that then allows them to have an open wound or even an infection on the foot that, unless somebody looks at it or they notice it, they may not have any symptoms from that. And so we have to clarify when we say, oh, well, somebody got a procedure and they didn't have symptoms. Well, they may not have had pain, but if they had an open sore, then that would be one thing. But I'll just say, in general, if somebody's totally intact, they don't have an open wound, they don't have profound blockages that would cause that, and they don't have symptoms, they should not have procedures, at least of the lower extremities. Typically, we don't do these things in a preventive manner. And so I would say with all of these things, there are always shades of gray, but this is one thing that's not gray. That is that if patients are getting procedures and they have no open sores and no symptoms, that's not a good thing. And I would say 99% plus of doctors would say that that's outside the bounds. That wasn't really clear in the story. They threw that idea out there, but they didn't really present anyone who went through that. The patients they presented were patients who were in already a super high limb loss risk category, if that makes sense. So remember, I mentioned
right.
if somebody's progressed to modern day leprosy, you can throw the entire most skilled, most sophisticated, most innovative procedures at them to try to get them to heal. And still 10, 20, 30%, depending on how they presented, are going to lose the leg. So if you start saying, well, geez, there were this many amputations, that means absolutely nothing if you don't know the denominator. So if there were 50 amputations in 50 patients, you'd say, oh my gosh, what are we doing? But it's 50 amputations in 500 patients. That actually might be a very good result, depending on the severity of the CLTI that the patients presented with. So then the one other thing I'll just say is that, and I already mentioned this, but let me just reemphasize it. The other thing that most doctors agree with, and I think is in all the guidelines, is that if somebody presents with claudication, that is inability to walk, but they have intact tissues, they don't have an open wound or an infection or a gangrene, they present with inability to walk, the vast majority of those patients should be treated with medical management first in the manner that I just mentioned, because many will improve. There's going to be the occasional person that literally can't get around their own house, and you don't have months and months to do medical management. So that person might get treatment a little earlier. And, and this has been the point of some contention, because if you look up in the Medicare database, and you say, okay, well, this many procedures or this many patients got procedures for claudication, how many of them had well-documented medical management? So this is a place where somebody could look those numbers up and say, well, geez, we need to do a better job kind of giving the patients all the options and not just the flashy, kind of exciting, type of procedure approach.
The story sort of indicated directly, maybe indirectly, that atherectomies can further inflame patients' arteries as well, and as a result of that, leads to more amputations. Is that right, or is it not correct to suggest that's the case?
That's worth discussing, and let me just say, part of this, I know we're going to get to it, part of this whole discussion is, outpatient versus inpatient, atherectomy versus other. And let me just say that this whole idea of outpatient treatment was partly related to doctors and partly related to the government. If anything, more related to the government. Rules coming from CMS really suggest that they would strongly like to have these patients treated as outpatients. And that's the way it's set up. And there's some important benefit in that in the following manner. One, these procedures, so I'll just give an example. Many years ago, at the beginning of my career, all of these patients would have been treated as an inpatient. So when I was a vascular fellow, I'd come in the hospital in the morning, there'd be 60 patients that stayed overnight. Now all of those patients go home. Out of those 60, 2 would be in because they weren't quite ready to go. So this is a massive improvement in what we can do for patients. These procedures have become safer, they've become miniaturized, they've become innovated to the point where we can open up blockages and restore blood supply using these minimally invasive techniques, whereas before we used to have to do a bypass, for example, on every patient. And then in the early days of these catheter-based techniques, we still had to keep them as inpatients for a variety of reasons. Either we were worried about bleeding from the needle hole or something like that. So that's the backdrop. So a lot of these folks are being treated. So when I used to be in practice in Hawaii, I would have people come from Kona, from Maui, from Hilo in the morning to Honolulu, get a procedure, and then go back home on the plane that afternoon. And those patients wanted to be at home in general. And so this is a massive improvement in what we can do. Okay, so now let's say, okay, so before we leave that innovation outpatient part, I don't know, Justin, if you had something else you wanted to add there.
Well, I think, Peter, the historical context you're providing is really important here. And it relates a lot to a couple things, including how we've learned to manage this disease better, but also the fact that there has been a history of innovation in this category that's enabled us to do more procedures in lower cost settings that improve access to care and with better outcomes for patients. So progressing from a more invasive surgical approach to a same day, minimally invasive, quicker healing and quicker return to work or sort of restoration of your quality of life has been the objective all along. I think what's complicated about this story, though, is that while there's been growth in procedures, it's in response to growth in the need. And when we think about this disease, it's not like we have one part of the anatomy that just fails. It's not like a valve fails, we replace the valve and we fix the patient.
Right.
This is a multifactorial condition, and it's a diffuse disease in patients where there are many lesions throughout a patient's leg, typically upper leg and lower leg. And we take a toolkit-based approach using the best available innovative tools we can to very precisely try to reestablish blood flow. We've also learned that things like stents that behave well in the heart and coronary arteries don't behave well in the lower legs. And so we attempt things like atherectomy, which is really a minimally invasive tool to carve out that sludge and plaque buildup in the legs that Peter described, like in the house pipes, and remove as much of that obstruction as possible without leaving behind a stent. And we pair that with other interventions that ideally best position that patient with improved blood flow and the ability to heal, these soft tissue injuries and infections that otherwise will progress and require amputation.
That's really helpful context. It strikes me as I reflect back on the story, to some degree, they were suggesting that healthy patients kind of are talked into having an atherectomy, if you will. In many cases, they don't need it at all. And Dr. Schneider, from what you're saying, and then Justin, what you added as well, that doesn't seem to be the case at all, right? That these are patients that present with serious problems, and if something's not get done, they're going to have other longer-term consequences that could be much worse than that. It's, Dr. Schneider, a very thoughtful approach that I think a doc would go through in order to avoid surgery, but then do it only if it helped outcomes. Is that right?
I think that's a good, reasonable rule of thumb. It's a good way to think about it. I think also, as Justin mentioned, we have a variety of tools, and we're trying to do the best we can for the patients, and of course, doing our best not to do damage. Because this is a chronic, what I would call inflammatory condition, and by the way, a calcification or hardening, it's a kind of a post-inflammatory marker. So in other words,
right,
the calcification tends to become worse over time. And I mentioned that atherectomy is specifically its sweet spot, or the place where it was designed to work, typically is in calcified arteries. The controversy about about atherectomy comes from a couple of things. One is we don't have good head-to-head treatments of studies of head-to-head treatments of atherectomy versus other things. There have been some randomized trials, but none that was definitive enough to say, aha, this is exactly when you use atherectomy, and aha, this is
right,
exactly when you don't need it. And so there's a wide range of, there are people that, the docs that are really absolutely convinced and their practices are quite dependent with this as a primary tool. And there are other docs where they don't use it at all, or they use it occasionally. And the question comes, well, could they be seeing slightly different populations, for example? And there is some literature to suggest that atherectomy does not work better than other things. The challenge is that it's not individual patient level literature, it's these larger databases. So, and I'll give you an example of a study. The study looks at Medicare patients and says, well, gosh, the patients that had atherectomy were more likely to need a repeat procedure. But then you'd say, well, wait a second, what if the ones who got atherectomy were the ones who had the worst calcification? Well, it can't answer that question.
Right.
So there's an association, but there's no clear causality between the atherectomy and negative effects. So, like I said, calcification is worsening. I think the idea of taking away a tool or trying to, restrict the use of a tool that is specifically designed for calcification doesn't make any sense. However, this wide range of variability is something that I think the medical field, we really need to deal with. We need to design studies that would help us understand what's the best time, best situation, conditions, say amount of calcification, location in the body, value of stent avoidance, as was mentioned by Dr. Klein. All of these things really are looking at more of rather than thinking of atherectomy as a specific tool, we should be thinking more about algorithms of care and what's the right combination of things, atherectomy plus perhaps a drug-coated balloon to get more drug into the wall of the vessel and to slow down the inflammatory process that occurs. So
I want to seize on what you said earlier about the repeat customer concept, right? That was a term that was brought out of the New York Times article, that quote, sort of a repeat customer concept. And then there were two other quotes connected to that, Dr. Schneider, I want to read for you. One, it said, it's a niche medical field that really favors aggressive interventions. And then as a result of that, there's a clear business motive for treating people with no symptoms. It just strikes me that characterization is just completely off base, not only from a medical standpoint, but also from the perspective of what a doctor does for patients who are suffering.
Yes. So this idea of a business motive, I think it's, you can tell I'm looking for the right words, because this implies that you're in the head of someone else.
Right.
That you understand their motivation. That's a pretty strong statement. Right. To show up in a national newspaper, whoever said it must be really convinced that they can mind read, that they fully understand. Hopefully they've maybe even gone out and talked to these docs who are using a high volume of atherectomy. I can't hang my hat on that. I think it's too strong of a statement. I think there is quite a bit of variability. I will say that let's just say if there is a group out there, hopefully it's not a large group, but if there are a few docs out there that are using a specific tool as a business proposition rather than caring for the patient, I hope they come to their senses immediately. I don't think it's good for the patients, and it's definitely not good for our field to have folks that are on the edge. I think if it's true, I don't believe it can be a very large group. I think this is more driven by a couple things we already mentioned, but probably the most important of which is this high variability with which people interpret the data. And there's lots of data. If you look for data on PubMed on lower extremity atherectomy, there are literally hundreds and hundreds of clinical studies. It's just that everybody's interpreting them a little bit differently. I don't know, Justin, if you were going to add something to that.
I think one of my concerns with how the article positioned this question or this evidence of seeing patients have multiple procedures and then still have an amputation, or even implicating those procedures increase the odds that patient need an amputation, is a bit unfair, and it's outside of the context of how clinicians approach late stage, CLTI and complex PAD. Unfortunately, frequently these patients have so many lesions and such complicated disease that you couldn't possibly have a single session of pursuing each lesion that needed to be addressed in order to reestablish blood flow without subjecting the patient to hours and hours of anesthesia and potential other complications associated with any procedure. And so clinicians frequently do their best to start with the most critical lesions, take reasonable precautions around the procedure, do their best, and then see how the patient does, with a plan to bring that patient back if necessary, based on further review of their clinical progress and response. And to think that one might characterize the whole field as being rife with sort of perverse incentives just feels unfair. I think Dr. Schneider's analogy to cancer is an appropriate one. We see oncologists treat patients with cancer with first line, second line, third line, fourth line, fifth line drug therapies and other modalities, doing everything we can to prolong that patient's life and ideally save their life if we can. And we don't criticize them for being aggressive in treating that patient's disease. I think the same thing is happening here with CLTI. When you're a patient facing the prospect of a foot or a limb that requires amputation, you want to do absolutely everything possible to try to save that limb and avoid that amputation. And unfortunately, sometimes it's not possible. But I think it's the right thing to do for these patients to provide them with the right information, a treatment plan that they develop with their clinician, and to do our best to save these limbs.
I always worry when I read stories like this out of the New York Times that the sweeping, broad generalization of a doctor sort of business relationship has really a chilling effect on procedures and also patients' view of the patient-doctor relationship in a way that might cause people to delay getting treatment or delay having a surgery, resulting in outcomes that are much worse. Dr. Schneider, your thoughts on that? Do you share that concern? Have you seen that in any way?
I think that's the most likely potential negative outcome of this particular article that we're discussing now. And we know from our experience during the pandemic that if you scare the patients enough, they will stay home and they will lose the leg. And we had a kind of a spike, if you will, a dramatic uptick in the number of amputations in our hospital during the pandemic because people were too afraid to come in. I do think, and just to add a little more context to how this relates back to the whole field of lower extremity salvage, amputation, prevention, I described how CLTI is modern day, leprosy, if you will, how the mortality rates are like a cancer, how the numbers are increasing because of diabetes, because of successful life-saving cures in other areas, et cetera. But what I didn't describe is the fact that this whole field of amputation prevention or limb salvage, it's a poor stepchild, if you will. It's an orphan field in the sense that, number one, the patients that typically experience this, not to a person, but very often, are the most vulnerable patients with the most comorbid conditions, very frequently of a lower socioeconomic means, very often in situations where care is either not available or hard to get. That's one key thing. So a vulnerable population without a good voice, without good representation. So this population needs strong advocates. And within that advocate group, there are many, many people, but this is a group that's just assembling now. So in the sense that, multiple specialties, I'm a vascular surgeon and I've been dedicated to this for a long time, as have most vascular surgeons, but also there are numerous specialties, radiology, cardiology, others, many in other fields such as wound care, plastic surgery, podiatry, et cetera. It takes lots and lots of people in order to get our best shot at limb salvage. And then, so that's the second part, the multidisciplinary nature of it. And the third part, and probably the most important, is the fact that there has been traditionally a therapeutic nihilism in this group. So in other words, this was true when I got to Hawaii. It was so common to get a patient referred after the limb was unsalvageable. And they would have a gangrene. It would be very common to have a gangrene that had progressed to the point where all you could do to save the person was amputate the leg. And the idea was, well, there's nothing really we can do anyway, so we'll just wait until it's inevitable. So this therapeutic nihilism is something that still exists, although it's improved dramatically. So when you look at those three factors, that it's a group effort, that it's a super vulnerable population, that there's traditionally been a therapeutic nihilism here that wasn't true, say, of breast cancer. Of course, we're going to go aggressively after every breast cancer. When you look at those three factors, and then you throw an article like this out there, this is like a match to a dry haystack. I mean, this is not a time to be throwing incendiaries. This is a time to be building our team, building our coalition, building the voice of these patients that will help us to save more limbs, have these patients come forward earlier and not wait until things have progressed. And so I think this article does a lot of damage to the field itself. And that's why it's worth, I mean, we all have things to do, but that's why it's worth speaking up, I think, about this. The details of it are, you'd have to sort through tooth by, tooth and comb. But I think the bigger picture is that this does probably more harm than good to this population. And I hope we can get past it.
Yeah, I think anytime there's an article that leads with their legs were lost and doctors and healthcare giants profited, you have to wonder how accurate, and it certainly raises alarm for patients, right? They start there. And as a doctor, you're then fighting a losing battle in many cases, trying to convince them that's not what these procedures are about. And to me, it just strikes me as tremendously unhelpful from a medical standpoint. But I'm not a surgeon. I don't do it. And so, Dr. Schneider, it's really helpful to hear your perspective. Justin, I want to turn to you, back to that concept of doctors and healthcare giants profited. It's really important, and you know this from your time as a doctor, but also at Vensana Capital. It's really important that medtech innovators, the companies that create a lot of these tools, partner closely with the surgeons who actually provide the surgery to make sure, right, that there's coordination, that activities are well aligned, and that we're supporting the needs that the doc needs in order to do the surgery right. Talk about that relationship and how critical it is to outcomes, because it is essential to good outcomes.
Yeah, I'm happy to talk some about the process of innovation and how those collaborations happen, for innovation to happen successfully with impact. What I would underscore, though, is the point that trust is the most important foundation of our ability to improve healthcare and to do right by patients. And that's true whether you're a clinician, hoping to treat that patient appropriately, a patient evaluating what they need to do, or in my case, a venture capital investor that's trying to work with the entire ecosystem to identify unmet needs, figure out how to develop innovations that are responsive to all the considerations of the stakeholders, and bring those things to patients in a way that will improve outcomes. We rely on a strong FDA with rigorous standards for review, because that does bring trust. We want to see payers think carefully about our treatment pathways and things that patients need, and make sure that patients are getting access to that care. And we need all those stakeholders to work with us in an open, collaborative manner so that we can figure out the right way to both identify the innovations that need to be brought forward for the most critical unmet needs. We need to figure out how to invest in them so that we develop the best versions of those products, to fund clinical evidence that rigorously validates, the risks and benefits and cost effectiveness of those therapies, and then bring forward that evidence in a manner that allows us to both educate clinicians and patients about these new options, to train people effectively and develop referral patterns and the right interventionalists or surgeons to pursue and deliver these things. Right. All this depends on collaboration. And it's unrealistic to think that everyone has infinite time to give to what are extremely intensive processes at each stage of the innovation pathway. And so we do work carefully, and we select clinicians that are willing to give their time. I mean, probably most of our collaborators are academic clinicians and scientists who, as part of their mission, believe that supporting innovation and doing research and teaching and disseminating, good innovation is part of their core personal values and mission. All these things, come together to make our ecosystem one that can support innovation and continue to bring progress to improving all these outcomes for patients.
Dr. Schneider, maybe you can add in here as well. Like, innovation doesn't happen in a vacuum, right? It requires the surgeon, it requires the doctor, it requires the engineer, it requires the medtech company and the scientists there, all working together to try to find solutions to problems. There's no way one can do it without the other. The interrelated nature of it is critical, it seems, to progress. Is that your perspective as well from where you sit?
Yeah, I think Justin described it very nicely. It is a multifaceted, multi-stakeholder proposition that we're going to make any kind of improvement. The idea of Thomas Edison coming up with the light bulb. When you dig into that story, it turns out to be different than just somebody like some light bulb goes on. I think the most common things start with the unmet need that's identified on the front lines. It's some problem we're having. It's some inability to, in this case, we want to save every leg, not just most legs. We want every patient to live a long and healthy life and have full mobility and not be restricted in a way that they might have been generations ago. And I think it does take, as we haven't talked much about FDA or other regulatory bodies, but I think that what Justin said is very astute. We need as doctors, we're very often complaining about the FDA saying they didn't get this right or they didn't get that right. But the truth is that we need a strong FDA, and that they frequently are, very, restrictive is not the right word. They want to see evidence before they're willing to allow something to go forward. And I think that that's helpful. And I think also there's a reason why so much more innovation comes from the United States than from many other countries. Many other countries have decided that it's just not a priority for them to try to better the health of their population. They're going to wait until things are developed elsewhere, like the US, and then incorporate those things if they can. So I think we're in this, environment where it's a delicate flower, this process of innovation. Everything has to go right, the weather, the soil, everything has to be just right for something to work out. But thank goodness, very often it does. And don't forget that, one of those things I mentioned somewhere in the middle of our conversation, that this is what we hoped for. Many of these patients that we're caring for, that we're in this battle to save their leg, it's the group that may not have even made it this long in a previous generation. And most of that, a lot of that, is because of the innovations that have taken place in the meantime.
This has been very helpful. I want to cover two other issues real quickly. And Justin, maybe I'll start with you on this, and then Dr. Schneider, your perspective as well. Oftentimes in this article, other articles, you see this notion of the medical device sales rep thrown around, right? Individuals who come from the companies and work with doctors or in the operating rooms, as if there was something inappropriate about that. I've always thought to some degree that term was a misnomer, Justin, that these are really doctors and experts in the technology who are trying to help a surgeon understand exactly how the new technology works. And it strikes me that there's tremendous value in that relationship. Am I getting that right? Do you have further thoughts on that?
Well, I do. I think to narrowly think of a salesperson as strictly pushing a product onto a customer is a really shallow understanding of what it takes to provide care, particularly through medical technology, whether it's interventional or surgical, to patients. As we discussed, like in the case of peripheral arterial disease, it's a toolkit-based approach to really tailoring a procedure and a treatment to a patient. And that means there's multiple products, frequently used in concert together. There could be multiple sizes of products, multiple approaches to using those products. And a lot happens in the process of bringing truly innovative products to market that requires education and training and a long-term commitment to figuring out how to optimize and use these products over time. And that happens through collaboration between the companies that develop the products and, frankly, for a period, know the most about them of anybody in the world. And then their physician and surgeon customers who are really responsible for those with their patients, and they take that responsibility seriously. But it's a collaborative effort to make sure we use these tools the right way. And the sales professionals and marketing teams and clinical training experts and post-market development, all these things work together to make sure that we're not only bringing a product to market, but we're refining it and optimizing it, improving how we use it over time.
Dr. Schneider, do you want to add to that? Or
I think it's been well characterized. I will say the pragmatic workaday world says there is going to be some variability. There are going to be situations where, maybe somebody who's advocating for a, sale of a product is pushing too hard, something like that. This, of course, is where I think we as physicians have to be really careful about that kind of thing and about making sure that at every step we're looking out for the patient. Having said that, typically So when I finished my fellowship, there were no catheter-based procedures. And now 80% of what I do is catheter-based. So education doesn't stop the day you walk out of school.
Right.
And the same is true for medicine, medical specialties, as it is for every other part of life. The person that comes into the operating room to maybe help you or to be there when you do a new procedure, they might have seen hundreds of those. You might have seen none. Or one or two. I put it another way, the busiest doctor, no matter how many hundreds of procedures you do in a year, is not going to have seen as many and has seen as many variations on the theme as one representative who is looking at those procedures and being, watching and observing and discussing those procedures every single day of the year. The way I look at it, it makes my practice safer when I have the right people in the room, especially when I'm using sometimes not just a new technology. Sometimes I have, for example, in the area of abdominal aortic aneurysm repair, which is now 80% catheter-based. Again, when I finished my residency, it was 100% open surgery, all with big hospital stays. Now people get a catheter-based thing. They go home the next day. I've been doing that for that procedure of endovascular aneurysm for more than 20 years. And yet every single time I do one, I have the guy in the room or the woman, the representative from the company, because they will have seen thousands, whereas I will have seen maybe 1,000 or hundreds, this kind of thing. So anyway.
That is really helpful context. I think in defense of most readers of the articles, if they didn't know that, they could easily be confused, right? And so I think that clarification is really, really helpful. Let me close with this. I referenced it earlier in the generalization comment that I made, but people reading this story might be reluctant to trust their doctors and the devices that the doctors might want to use afterwards. What would you say to them? How should patients find doctors that they feel like they can trust and make sure they're getting the right type of treatment? Dr. Schneider, let's start with you. And Justin, you may want to add that as well.
There are some things that they can do. First of all, I think you want somebody who's board certified. You want somebody who's done a lot of what they're proposing for you. You want somebody who is not chronically facing malpractice suits, this kind of thing. And all that you can find on the internet. But I think also having a good track record in the community is really helpful. I wish there was a perfect way, but I think if you ever doubt what the doctor's saying, I think broadening the discussion makes sense. I don't know, Justin, what do you think?
Well, I would agree. I think those are important. I think the use of second opinions is something that I certainly try to take advantage of. But as a physician by training and as somebody that's tried to at least lend some of that expertise to my friends and family when they have healthcare needs, I can attest our healthcare system today is extremely complicated to navigate. I think in medical school, we learned what was maybe an older concept of this learned intermediary, right? The fact that through training and experience, physicians and healthcare professionals do develop a lot of expertise in an area where the average person just cannot. But with that comes a real responsibility to make sure that you are thoughtful about how you treat patients, how you think about approaching their care, how you recommend procedures or conservative care strategies or a plan over time. And I think it's important that people understand that a lot of us bring that exact same ethos to our work in medtech innovation. I loved my time in medical school and decided to pursue this career because it was an opportunity for me to leverage that background, but hopefully have a greater impact on more lives and more patients that I could see in my life professionally, daily, weekly, et cetera, through medtech innovation. And, the innovations that we support are the same products and procedures that my family will use or I will depend on in my life. I think there's a lot of us that align to that kind of ethos. And it's just an important message to reiterate for us and for the broader community, because like I said earlier, that trust is foundational for all of us to be in this together, to be successful.
That is very helpful context. And I will say, Justin, you're right. The healthcare system is very complex, but the human body is even more complex. And it requires people who are dedicated to healing in order to make sure that complexity of the human body is aligned with the complexity of our healthcare system and get the best possible outcomes we can get. And Dr. Schneider, we're grateful that you're still in the business, and the work that you're doing for patients is tremendous. So Justin, thank you for all you're doing to help build that innovation so that 20 years from now and 60 years from now, patients are treated even better than they are today because of the progress of innovation. So thank you both for taking time to talk to us today. It's been very helpful, great clarification, and thank you for your work.
Thanks, Scott. Appreciate the opportunity.
Thanks, Scott. Pleasure.
For those of you listening, thanks for tuning in. For more episodes, visit advamed.org/podcast or subscribe to Medtech POV on your favorite streaming platform. Until next time, this is Scott Whitaker. Have a great day.